So nobody can seriously be against active surveillance. So 2 years ago I already said it's not a pro and con. And if we talk about con, it should be concerns. You cannot be really, in light of all these data we've seen today, be against active surveillance. However, I'm still here and alive because the reality is different to what Laurie just told us. And this is the latest data I have on the acceptance of active surveillance. And I don't know any more actual data than those published 2 years ago by Matthew Kuperberg. And you know probably this study. It's a capture database, and it's probably the most representative database on what people choose when they are faced with prostate cancer. And this is the low-risk group. These are the ideal candidates, the large and growing number of patients that are diagnosed today, low risk. And you see this little gray bar here. This is the percentage of patients who choose active surveillance as their initial therapy. So, despite all these things we see, at least in those years from 90 to 95, up to the year 2007, there seems to be no acceptance for this, and it seems not be very appealing. And the reasons for that, I think, are some points you have already told us. There are a lot of uncertainties with this strategy. The concerns are clear. We don't have a clear definition of low-risk disease. We might underestimate cancer extent. We don't have clear markers. We have lots at the horizon, but nothing that's been scientifically proven to differentiate between relevant and non-relevant cancers. We are not really sure that delaying the treatment might be as effective, and I'm not just talking about overall or cancer-specific survival, but as well as the side effects of the therapy. Maybe therapy might be better or worse for the patient if we treat him with a PT3 cancer with a non-nerve sparing radical prostatectomy than an early disease with a bilateral nerve sparing radical prostatectomy. It's not only all about overall survival. And certainly active surveillance has side effects, and I go through all these points in the next minutes. So in 2010, I showed you this slide, and I showed it for the reason that we don't have clear definitions. So low-risk disease is something that is interpreted different by different people and different groups. This is just a small example. There are some people consider PSA below 15 being low risk. Some people consider high-grade cancer, 3+4, for example, as a low risk as well. Some people consider T1C cancers, others not, as low risk, and so on. So there's no clear definition on that. And 2 years later, there's no still consensus. There's no clear fact. There are some accepted definitions, probably PSA below 10, Gleason 3+C, T1C cancers, but this is not uniformly utilized. So the concern of the patients is that we might underestimate the cancer once it's diagnosed, and it's true. We have to face that, and there are lots of studies out showing that, and I just want to give you one example from our group together with a group from Francesco Montorsi. Almost 5,000 patients we looked at with low-risk disease, and you see a couple of definitions from Hardy and co-workers Römling. This is from Laurie Klotz's group, this as well. So different definitions, types of low-risk disease, candidates for active surveillance. And then we looked, those patients who underwent radical prostatectomy, do they have unfavorable disease? And regardless of what scheme you look at, there are about 39 to 61% of patients who have either high-grade cancer, PT3 disease, positive lymph nodes, and so on. So even using the most strict criteria out of all these schemes, we had a 30%, the most strict criteria, 30% of patients who had more aggressive disease than we expected. And this is the other reality that patients have to be informed about. So we don't have any markers and nomograms. And I just looked at the literature that came out in the last couple of months. And this is the master, the god of nomograms, Mike Catan, and he's just published an overview looking whether it's possible today with a nomogram to identify relevant disease. And you see his conclusion. Even today, in 2012, no nomogram is able to identify safely, and we still have a up to 20% misclassification, and we cannot exclude the presence of adverse pathologic features published a couple of weeks ago. This is a slide from 2010. Just as an example for all these biomarkers, Laurie has already mentioned that we were talking about, that I don't see anything at the horizon that we can safely tell our patients this may be another substance we can use to identify aggressive disease and differentiate it from no aggressive disease. PCA3 was one of the candidates, and this is a study coming from Johns Hopkins Clinic based on patients who are on active surveillance. They checked the PCA3 level and looked whether the patients progressed on the next biopsy or not. And what they found is that the PCA3 levels of all these patients are, as you see here, all over the place, concluding that PCA3 score is not significantly associated with short-term biopsy progression. Are there other markers? I just found one in the literature of the last 2 years, looking specifically on patients in active surveillance programs, and pro-PSA was the only candidate I could find, but this is only 71 patients. And interestingly, when I look further into this publication, the same cohort of patients, 71, was published in 2009, so there's no real progress I can see. This, I think, is the most important question, and that's probably what you face when you talk to patients, come with low-risk disease to your office and discuss with you how to treat that. It's the fear that delaying the treatment might be less effective. And one major point, as I said before, is not only will I die from prostate cancer, but will you be doing, for example, a bilateral nerve-sparing prostatectomy if I delay my treatment for 1.5 years or so? That's a question that is well asked by the patients. So in 2010, if the patient asked me, can you guarantee me that delaying the treatment is as effective as immediate treatment, I had to say no. And I looked at, and I showed you the data on that. Just 3 examples. A very often quoted study from Stephen Friedland. So what he did, these are all patients with low-risk cancer treated with radical prostatectomy. And they delayed their therapy 3, 6, or more than 6 months. And you see the Kaplan-Meier curves of PSA recurrence. This is up to 6 months, and this is more than 6 months. And you see that there's this 2.7-fold increase in PSA recurrence rates when the patients with low-risk disease delayed their therapy by 6 months. We've seen this. This is from Laurie. And how do we interpret this? So you told us for the whole cohort, the recurrence rates is probably as high as with surgery or radiation therapy if you look at the whole low-risk cancer patients. But what do the patients see from this? The patient realizes, and I think it's worthwhile to think about it, if you be on an active surveillance program and you are reclassified and then treated, it means that after surgery, after being treated with radical prostatectomy, even though you had a low-risk disease, your likelihood after 5 years of not being cured is about 40%, and even higher with radiation therapy. We heard about that this might be not the right type of radiation therapy, but I want to quote Laurie, among those patients who were reclassified as higher risk and who were treated, PSA failure was relatively common. These are patients, or this is another study that was brand new 2 years ago, and I mentioned that, showing patients who delayed their therapy, radical prostatectomy, and they looked at whether the pathologic outcome was unfavorable or not. And you see that there was no statistically significant difference, but if you look at the Kaplan-Meier curves, you can see that if there was be a double size of patients, it probably would have been statistically significant. And they also stated that also all data, there was no statistical significance, all data were in favor to immediate radical prostatectomy. So what happened in between 2010 and 2012, since we talked about this last time? 4 studies I found, looking at treatment delay, patients on active surveillance, and then treated later on, and the data are conflicting. One study from Delera showed, comparing 33 men who underwent delayed radical prostatectomy, compared that to 278 men, low-risk criteria, immediate radical prostatectomy, no difference in adverse pathologic features. Same from Sweden. Jonas Hugersson is one of the co-authors here. They compared 2,344 patients, immediate radical, versus 222 deferred radical prostatectomy, no difference. So this may be safe to delay radical prostatectomy, but there are some other data that we have to keep in mind that came out. One is that is actually in press. It's from the PRIA study. We talked about that study already. And they didn't look at survival rates because they don't have something like a control group. But what they looked at is whether patients have adverse pathologic features or not once they were on the prior study and then reclassified. So 167 men underwent deferred radical prostatectomy, and the time between starting the active surveillance program and then undergoing radical prostatectomy was a bit more than 1 year. So I'm not sure what they gained by this year. Nevertheless, unfavorable radical prostatectomy results, which was considered PT3 or PT4 cancer, and Gleason 4, leading 4, not just the evidence of 4, but 4 plus 3, was there in a third of the patients. So patients have to be informed about that. I don't know whether this is due to the delay of surgery, but this is one of the results we have to consider. And finally, the last of these 4 studies I found came from Bill Catalona's group, pretty similar to what we saw from Stephen Friedland, a bit more than 1,000 patients with low-risk disease, and again they looked at the effect of treatment delay, looked at half year and less than half year, and again there was a significant difference in pathologic features and as well as in PSA recurrence when those patients with low-risk disease delayed surgery. So what is my answer in 2012? Still the same. There are conflicting data, and I cannot guarantee a patient today that his treatment might be as effective when we delay it. Active surveillance has side effects. We talk a lot about psychological aspects, and usually when the psychological burden is investigated in active surveillance groups, it's not a lot of burden for those men. But you have to consider that this is a highly selective patient. Those 10% who choose active surveillance, those who are cool enough to live with the cancer and not to be treated. So this is a nice, I think, very, very balanced overview just published recently by Chris Bangma, and still the fear of progression is the main reason to reject active surveillance as one of the conclusions of this paper. Loss of potency, we talked about a lot of impotence as a factor or a side effect of the treatment. You know this study probably, I showed that slide as well 2 years ago, and you see this is an active surveillance cohort from Johns Hopkins, and you see the number of biopsies, and you see the drop of potency, and you see after 5 biopsies the drop was about 8% in the SHIM score. By the way, the average drop of potency SHIM scores in a bilateral radical prostatectomy performed in our center is 7 points. So you have to consider what you lose when you undergo a bilateral nerve-sparing radical prostatectomy as an example. So biopsy is not something, can harm the patient, and this is a publication that was just presented 3 weeks ago at the last day of the EAU meeting from the UK, and it's coming from the PROTECT study. And what they found out, they looked at those patients in the PROTECT study who underwent biopsy and then asked what this biopsy means to those patients. And it's more than 1,000 patients, and you see outcome of biopsy, 43% of the patients considered or stated that they have substantial pain, and almost 20% develop fever. I think that's a bit high, but these are the data from the PROTECT study. And what they as well did, they asked those men who underwent the biopsy whether they considered a further biopsy a major or moderate problem for them. And they asked them immediately after the biopsy, and 10% said, yes, that will be a major or moderate problem for me in the future if I have to undergo another biopsy. And you might think that this might decrease with time, but no, it actually increased. After one week, again, the same patients asked, 20% of them said, another biopsy would be a moderate or major problem for me. One slide that has been shown before by Jonas Hugoson, and I think this is something that shows that we were not doing everything wrong with patients, treating them aggressively with prostate cancer. So this is Cancer Statistics 2012, and you see the drop of prostate cancer death that started in the early 90s, and it's steadily declining. You see as well that lung and bronchus cancer is declining as well, and colorectal cancer is declining as well. So this is a good job, actually. But the more important thing, the sentence I got out from this study is the following. They stated that the decrease in lung cancer death rates among men was due to the reduction of tobacco use. However, the decrease in death rates in prostate cancer largely reflects improvements in early detection and treatment. Just 2 weeks ago, there was a systemic review looking at the Cochrane database and PubMed publications, a systemic review on active surveillance in men with localized prostate cancer. And what they concluded, to my surprise, actually was that evidence is insufficient to assess whether active surveillance is an appropriate option for men with localized prostate cancer. That's what they state from the Cochrane database. So, 2012, second round, Laurie. Active surveillance is an important but obviously not very appealing treatment for low-risk prostate cancer. We still cannot safely identify those men. It might lead to undertreatment, and it has side effects. And I like to close my talk again with a quote from you. We have to do additional studies to safely identify those men who are really good candidates. Thanks a lot.
Thank you very much. And now questions for the floor?
Can I make
Yeah.
Markus, I don't know if anyone presents the case for overtreatment as compellingly as you do, but the one piece of data that you showed that compared PSA failure rates amongst patients treated up front versus patients treated after a delay. Usually the patients treated after a delay are selected out of a surveillance cohort. And so you cannot compare them. It's like comparing the results of salvage to adjuvant radiation head to head. You have to include all the patients who remain untreated to calculate the PSA failure rate in that group. So I think it was the Catalona paper. I just want to emphasize that I think that's a misinterpretation of that data. You can't really compare those two groups without knowing what the denominator is.
I fully agree, but I like that misinterpretation, to be honest. And the thing is, so what should I tell the patient? So if you will not be treated and you are in a group that is those who progress and then when later treated, then you have the same likelihood as a group who is directly treated. That's the interpretation I should tell the patient. I think it's still
I'll just make one other point. We somehow in Canada do not have this problem of the patients being anxious and rejecting surveillance. It's become very prevalent, and I think it's a matter of how you frame it. And one of the phrases I use all the time is, there is no risk-free strategy. So yes, they will have a risk of missing the boat, but all the evidence we have is that the risk of actually having progression to metastatic disease and death is very, very low in these patients, whereas the risk of side effects of treatment is not so low. So they have to balance those.
Honestly, it all boils down to the way you present things to patients. Usually, whenever I see a patient, then there is a macro focus, you name it. I would tell a patient, you know what, you're exactly the same as half of the people who run down University Avenue in Toronto. And I tell them, I would be the dictator of Toronto. I decide that every single prostate will be removed. I don't want to know your name. I just want to know your age. I take it out, and I'm going to find it. And then, really? Yeah, 50%. And then they say, wow, okay. Let's meet in 6 months. It really boils down to the way you present things. And I think we share an enormous responsibility.
Oh, I just want to make a comment just to get things right. So coming from a very active prostate cancer center, only 7% of the patients we operate on fulfill the criteria for active surveillance. All the rest, I think, are clearly significant disease, just to make that clear.
I agree to Alex. I think it depends how you describe the situation. When I see that in Göteborg we have 40% active surveillance, and in Switzerland also 30% in our center. So it's acceptable, and it depends on the kind of information. And I think the geologists don't want to perform active surveillance sometimes. And this is a learning process I think we have to introduce to our colleagues. Then we have really to reduce overtreatment and to say, and the next doc you will tell us what is the point, the cutoff to make treatment. So we have to make an answer to this.
I think there's one major point for those practice urologists who are the first counselors, at least in Germany. So the role for them in active surveillance is very difficult because, so if you tell the patient, now we have detected the cancer, and then we do nothing, and if it's not progressing, then the expectation of the patient is, oh, this guy does nothing.
So
if he progresses, then he has done something wrong, and so you cannot really make...
I think we need another expression for cancer. When we have a Gleason 6, we have another neoplasia, another expression for this. This would be that the fear of cancer to dying within 1 or 2 years does not exist. That we have to tell them.
Question to both of you. Dr. Klaas, you pointed out that all the cancers that didn't progress, misreads, biopsies. Does that mean that you should reread the biopsies before putting a patient under active surveillance, ask another pathologist to look at every biopsy?
So I'm actually going to address some aspects of this in the talk I'm about to give, but I think the pathology is clearly critical. So you either need to have the tissue read by a pathologist who you know has an interest in prostate cancer or get it reevaluated by one who does. That is an essential part of this.
Quick question. PSA recurrence after radical prostatectomy are not all created equal. Do we know anything about the PSA doubling time or the kinetics of any of these failures? Are any of them really significant?
Well, in our experience, 5 were significant, and the 5 guys who died all had a short doubling time. We're actually just putting that data together, the analysis of the roughly 200 patients, of the 200 patients who've been treated radically. There's, the 40 or 50 who have biochemical therapy. I don't have that for you now.
The majority of men who have a radical prostatectomy up front, who have a PSA failure, we tend to watch them until their PSA reaches a certain threshold or their kinetics.
Jerry, I think it's a great discussion. I think we can, continue after the session, and now we have to go on. And I can ask once again, Laura.